We envision a movement.
We envision a movement.
We envision a movement of God's people.
A movement of God's people.
God's people who choose daily.
Who choose daily to promote healing
in marginalized communities in the name of Jesus.
In the name of Jesus.
In the name of Jesus.
So, Art, I really appreciate you making time for this today. I've been wanting to do this for a long time. I've heard your story and the Lawndale story so many times from so many people. I've never heard it from you, so I'm eager to kind of get your story on this. Lawndale has been a kind of a flagship clinic for CCHF and for the movement that we represent for almost 4 decades now. And Lawndale has helped so many other clinics around the country get started and has been an inspiration and coached and mentored people through. You've done that a lot. And so a lot of the clinics around the country have really benefited a lot from your openness, your generosity with your time and your experience. And I appreciate that this morning. How did you come to Chicago? Are you a Chicago guy?
Yeah, I grew up in Chicago. I went to med school at University of Illinois. So yeah, I was always in the Chicago area.
Yeah. And then how did you get involved with Wayne Gordon and with the guys that initially kind of became the foundation for Lawndale?
Yeah. So my wife and I well, first of all, I went to med school because I really wanted to go overseas. I really thought I was going to do third world medicine. I grew up in a Christian mission, Alliance Church. Half of our budget was always spent on missions.
Yeah.
They would have mission week, and I would see these docs come back and talk about their work. And I said, yeah, that's what I wanted to do. So that was my motivation to pursue medicine in the first place, and thought that that's what I would end up doing. So when I started medical school, my wife and I got married after my second year of med school, moved to Chicago. Linda was from New Jersey, didn't know anybody here, but her roommate from college, and Gordon was also getting married 2 weeks later.
Okay.
So that was the initial connection.
So Anne is Wayne Gordon's
wife. Yeah. Right. And so they had moved into the neighborhood. They had started a Fellowship of Christian Athletes Club.
Mm-hmm.
The kids got together. He was having Bible studies, was trying to get them to go to church in the neighborhood because there's plenty of good churches in North Lawndale. And the kids said, well, if that's what a church is, he had some Bible studies on what is a church, why was it important to worship together? And the kids said, well, if that's what a church is, why don't we start our own? So the idea for the church actually came from a small group, probably a dozen high school kids and one mom of one of those kids. So that's how things got started. So I was at that time, a third-year medical student. There was no limitations on how hard they could work you. So I was literally spending 100 hours a week and spending most of my third year at Cook County Hospital. And I was seeing from that perspective what health care looked like for people from our neighborhood here.
Mm.
And there was a lot of patient blaming, a lot of frustration on the part of the residents and the attendings. Because they were coming from a very different perspective. And at that time, if you were uninsured, you could go to Cook County's emergency room. They could diagnose your heart failure, your diabetes, your blood pressure, high blood pressure, whatever. The waiting time to get into the adult clinic was 6 months.
Oh my gosh.
So there was this huge lack of access to neighborhoods, people in neighborhoods like this, particularly if they were medically uninsured. But that wasn't what I was planning to do. But we did decide to help them start the church. So I was a third-year medical student. So it was February of 1978, we opened the church. But I had already planned, again, my plans were to go overseas. So I had lined up a 3-month rotation in Liberia in the beginning of my 4th year medical school. So summer of 78, we went to Liberia, had a great experience. We were the only emergency room open in the country. 2 medical students ran the emergency room. We rotated every other night, but it was a great experience. I came back thinking, yeah, that's what I want to do. But in that fall, by now I'm a 4th year medical student. One Sunday morning, Wayne Gordon put up a blackboard, said we need to do more than just preach on Sunday morning. We need to meet the needs of our neighborhood. Let's list what those are. First thing that went up on the board was a safe place to do laundry, because they're basically North Lawndale was divided in half by two gangs: Vice Lords to the west, Disciples to the east of a street, Pulaski, which is actually where the church. So the church kind of sat right on that borderline, and women were not feeling safe in the laundromats. So the first ministry was we were in a storefront across the street from where the clinic is now. And so the first ministry was to get people to donate washers and dryers and put them into the storefront, so they had a safe place to do laundry. But the second thing that went up on the board was a place where people could come and get primary care. They could get medical services. So they all kind of looked at me. I'm a fourth-year medical student. My plans were to go overseas. I wasn't planning to stay in Chicago. I lived in Chicago most of my life. I thought, well, we'll go do a residency someplace else. But they kind of looked at us and said, well, is that something that you would do? And Wayne Gordon had already kind of, he was seeing the need from his perspective also, and was already kind of planted that seed a bit. So my wife and I thought about it, prayed about it, and decided that that's in fact what we should do. So we made a change. And so suddenly I went and changed all my applications for residency, got into University of Chicago and for my internal medicine residency. So that was how it sort of got started. The church over years has done that same kind of thing where it said, well, what are the needs in our community? And responded with various ministries, whether it's housing, whether it's legal aid, whether it's recreation, whether it's preschool. But the clinic was part of that. So I went and did my residency. We really weren't ready to start a clinic. So I stayed at U of C for another 3 years, did chief residency in medicine, and then did a cardiology fellowship. Which people say, well, why did you do a cardiology fellowship if you're gonna do primary care?
Do primary care? What?
Yeah, it turned out to be in retrospect. I mean, it was just God's leading. It was really the way to make things sustainable financially going forward. So when we finished my training, we opened our health center in September of '84 with an internist, another internist, and myself. We had a total of 5 staff. So Janice was an internist, had finished her training. We had a family practice doc was going to join us in 3 months, and we opened the clinic. We got Rob Wood Johnson Foundation grants. So what was interesting is that at University of Chicago, none of them understood why I was deciding to do primary care when I was finishing a cardiology fellowship. And they all were, well, why don't you go do academics? But we felt like this is what we should do. Meanwhile, we had moved into the neighborhood. So we moved in when I was just finishing my internship. And so we were already moving in the neighborhood because we felt like it was important to understand from the neighborhood's perspective what the healthcare needs were, because it was more than just medical needs. So we moved into the neighborhood in 1980. Lived here for 34 years. So we were kind of learning I was learning for my residency, the medicine. I was learning from my neighbors here what it was going to take to be successful and have a successful clinic that was really addressing people's needs. So that's kind of how we got started. We opened in '84. We had an 8-year grant from the Rob Wood Johnson Foundation, amounted to about, and it was a matching grant. So we had to get matching local foundation money. I didn't know how to write a grant proposal, but somehow figured out how to do it.
They didn't teach you that in.
They did not. Yeah, yeah. But it was interesting the way we actually started getting funding foundation is we had bought this building. So the building where the initial clinic, where the main site is now, was an old Cadillac dealership. It was Emil Denemark, which is where reportedly Al Capone would come and buy his Cadillacs.
Oh.
So it was, and this North Lawndale is also the neighborhood where Martin Luther King lived in the 60s for several months to demonstrate that housing discrimination was not limited to the South. So in '68, the commercial strips in Lawndale were pretty much burned down, including Ogden Avenue, which is where the clinic was. So this building was at one point a Cadillac dealership. Then it got bought by the Salvation Army. They ran a thrift store here. But Salvation Army didn't have the money to keep it up. And so the building was crumbling and condemned to be torn down. They would the roof would, in several parts of it had collapsed. There were holes in the roof 30, 40 feet across where the roof had collapsed.
Oh my goodness.
And so it was the Salvation Army moved out. The storefront that the church was meeting was right across the street. And so they offered to sell us the building for $35,000, which so we didn't have $35,000 or any way to fix it up. But gradually we raised the money internally. We had a lot of volunteers. Architect that came in said, because we had several architects come in, and the first several all said, "Well, just tear it down." But we didn't have the money to tear it down. We didn't have the money, $35,000 to buy it, let alone the money to demolish it. But we had one architect that said that he thought we could restore it and fix it up, and he wasn't going to charge us anything. Well, the price was right.
The price was right.
Yeah. And so gradually, we started working on the building. We got a lot of volunteers, both from in the community and outside the community, that came and helped us to rehab the building. And then one of those days, and Wayne was there with several of the high school kids. They were repairing the roof, and a lady from the Chicago Community Trust, who did most of it, which is one of the biggest foundations in Chicago, came by because we'd put a proposal in, and she looked up and saw all these kids in the summertime working on in the heat, stripping down taking the roofing material off the roof. And so it wasn't that we wrote a very fancy proposal. It was she saw that kind of community commitment. So she decided they were going to fund us. They gave us $150,000 to finish the rehab in the building. But once they come and fund you, then it becomes almost like the housekeeping seal of approval, right? And the other foundations started lining up, and we got Robert Johnson money as well. So we opened in September of '84. We had what amounted to about $100,000 a year, which I went back recently to say, well, what's $100,000 in '84 worth? Now it's worth about $300,000 in operating support. We were not a federally funded clinic. We were not a FQHC lookalike. In fact, there was no such thing. So there hadn't been a new federally funded clinic in over 10 years. And their FQHC lookalike legislation wouldn't pass until 1989. So we started off charging $5 on the sliding scale, flat fee for the uninsured. And for a 99213, an established patient, we got $13.65. So that's how we got started. And fortunately, I had done a cardiology fellowship. So I looked at the local hospital who actually didn't have a cardiologist. They had the highest amount of uninsured and Medicaid patients in the state, except for the Cook County Hospital. And even though they were 2 miles down the street from Rush and University of Illinois and others, there were no cardiologists that were interested in working at the hospital. So they had internists trying to act as cardiologists. It was a small hospital, 100-bed hospital, but it was one of the main hospitals that was serving this community. So I started off teaching to be able to draw a salary because I couldn't draw a salary from the clinic. Started teaching at the University of Chicago and started hospitalizing my patients at Bethany Hospital, only to find out they didn't have a cardiologist. So they asked me if I would run their heart station and run their ICU because they really needed someone to do that. So I got out on my teaching contract at the university and started to do that. So I was seeing patients, primary care here, doing the cardiology at the hospital, and that became our business plan. Because $100,000 really was not enough to meet the needs. So that was like the first 3 years. And then 1987 came along. And meanwhile, the church was gradually growing, doing the same things. Wayne Gordon was the pastor. He's very much a visionary, very much pretty good at being able to attract funding and resources, but also very careful to make sure that the community was owning that it wasn't being driven by outsiders, but really being driven by people in the community. So the church was kind of growing at the same time. And then financially, we got involved with managed care in 1987. So at that time, Medicaid was voluntary. In terms of Medicaid managed care was voluntary, which meant that the patients could stay on the fee-for-service or they could join a managed care company. The managed care companies were adding some value-based benefits, so a lot of people in our community were starting to join these managed care companies. So they came looking for clinics to do primary care. They came knocking on the door, said, "Do you want to be part of it was called Chicago HMO at that time?" And I said, "Sure." And they said, "Oh, by the way, we don't pay fee for service. We pay capitation." I said, "Well, what's that?" Because somehow that got skipped in medical school. I didn't know what primary care cap was. But I thought at $13.65, how bad could it get? And so we started with primary care cap back in 87. And then their strategy was an interesting one, which is every year they would come back and renegotiate the contract. And every year they gave us more financial responsibility. So gradually over the next 5 years, we became capitated for primary care, for specialty care, for outpatient diagnostics, for pharmacy, for the emergency room, for behavioral health, built our own back office, paid our own claims. The only thing we weren't financially responsible for was inpatient care, although we eventually developed risk contracts for that as well. And what we realized is that payment system actually made total sense to us, that if we could provide better access to care, if we can improve people's health, if we could, that in fact, there was a lot of waste in the system, people having to go to the emergency room because they couldn't get in for primary care, a lot of duplicative services, et cetera. And so we got involved with value-based payments back in 87 and never went in a different direction. So that got us up until, but still we were pretty small. Like we were seeing about 20,000 visits at that time, because even with the managed care dollars and the foundation dollars, we just couldn't expand beyond. And then legislation passed in 1989, creating FQC lookalikes. So it was at first a hard decision, because we had gone into, we clearly didn't want to be restricted in terms of sharing our faith, praying with our patients, et cetera. But we kind of looked into it and decided to apply. So we were the second FQC lookalike in the country to get approved.
Really?
Yeah. So at that time,
and that was in 1989, or
the legislation passed in 1989, and it became operational in 1990. So we started getting then cost-based reimbursement. So suddenly, instead of at that time we were getting $17 for a 99213, it went to like $55. And what we did, the first thing we did was we hired a chaplain with that additional dollars. But we were doing pretty well from a managed care perspective, and now we were getting cost-based reimbursement. So gradually the clinic grew. We were always careful our priority was to hire staff from the community, and also, to the extent possible, was to influence our providers to seriously consider whether or not God was leading to live in North Lawndale. Mm-hmm. So, which I'd never regret that decision. That was always really important for me, was to be part of the neighborhood. So we started to just get docs that were interested in that. I mean, going back even a little before we opened the clinic, we went to probably, I think, the second CCHF conference. It was in Chicago. Mm-hmm. Janelle Getches was there. They had opened their clinic, Christ Community, in DC, which really impressed me. I met Carolyn Klaus, who was kind of at the same stage I was. He was thinking about opening up the clinic in Philadelphia, which later became Esperanza. And to me, it was really gotten exposed. John Perkins came and spoke. H. Spees was there and came and spoke. So they were really inspirational people. Mm-hmm. So I think CCHF has always been a really important part of us, and when we were getting started, and just a place where you could gather once a year and encourage each other. So that was kind of happening, and the clinic just started to grow. There was so much unmet need in our community that we eventually, and our staff were basically motivated to come and work here. It's actually kind of nice to not be able to offer them a competitive salary, because it was pretty clear that if they wanted to come work here, that they were going to make less than they could make someplace else. So we really had people that were mission driven.
Was recruitment tough that, or
recruitment was at times challenging. I can tell you, I also turned down people that wanted to work for us because I didn't have the money early on before we started to make some margin off of managed care and off of our getting FQC lookalike status.
Yeah.
And then we did get federally funded in 1992. So literally a month before the Ronald Johnson money 8-year grant expired, is the feds came knocking on the door. There was another federally funded clinic in Chicago that was involved in fraud. and the feds decided to close them down. So they came and said, well, you look just like, you're now an FKC look-alike, you meet all the requirements. Do you want to take the federal funding? And again, we were hesitant, again, to make sure that it wasn't going to restrict our ability to to provide really good care for our patients, but also to be able to, as our patients requested, to share our faith. I was just really pretty open with the HRSA person from HRSA that came and talked to me. I said, well, this is who we are. He said, I don't care. As long as you don't discriminate and say, you're only going to serve people of faith,
Right.
then it doesn't matter to us. You can't force people into this. You can't restrict people from coming based on their faith, but otherwise it didn't really matter to them. So that's when we got federally funded. I think we were the first CCHF type clinic. I don't think Unity had gotten it by then, or Christ Community had gotten federal funding. Maybe I'm wrong, but what I remember is we got
Christ Community was in the late 90s.
Late 90s.
Yeah.
So we had it by 92, and it was, again, God's grace that just a month started right after. Still remember what it was, $594,000. So now we were really able to expand. And I think what we've tried to do in the clinic is to take a holistic approach, and that really worked well by combining that with what the church was doing at the same time. The church was really important to us. They were doing a lot of the non-medical aspects of keeping people healthy. So they were expanding, as I mentioned, in terms of a lot of these other ministries that were, again, identified as needs. The clinic got involved with fitness. I never thought that was our medical need, but that was a vision of other people, including Bruce Miller, who said, we need to be more holistic. And so we started the fitness center. Things like the urban farm was never like, is that really what the clinic should be doing? But that was Wayne Detmer and others. So it was really interesting, was to be able to listen to other people and see the needs that they were identifying, seeing what was being laid on their hearts, and be able to support it through the clinic.
It's amazing what Lawndale has morphed into over the years. Y'all have continued to grow and grow responsibly. Just talking with you in the past and talking with Bruce Miller when he was here, I think y'all's philosophy was to go deeper, not wider, in the community. And I was talking to Wayne Detmer yesterday, and I started to make a list of some of the things that you guys, that Lawndale does. I mean, they besides primary care, integrated behavioral health, y'all were one of the first organizations in the country to attempt integrated behavioral health. It didn't always work well, but you guys have been kind of a champion for that. And
Naftali and Hunter Hansen were both early on, and Naftali's gone on, you probably know, nationally renowned in terms of his behavioral health integration. But
Naftali Serrano,
both of them started here, and Hunter before him. Hunter really had the vision for this, for behavioral health. Again, realized early on is that behavioral health was not a Medicaid covered service when we opened.
Wow.
So when we opened and started offering behavioral services, which made sense to us, is that it was not, we wouldn't get paid our PPS. It wasn't later on until they decided that behavioral health was not an optional service, a mandated service, and they would pay us our PPS rate. But when we started, it wasn't. So it was a struggle to do that, to make that work financially, but it was really important.
It's an unusual story because most organizations make decisions about the services they offer based on the financial viability of those things. Y'all did not always do that.
Yeah.
But at the same time, Lawndale has been well funded. It's you guys, operated on the cheap in the early years, but you guys have always, we were talking earlier that that having reserves was always a priority for you, and even though they were very scant in the beginning, it was always something that you guys built into. I mean, can you talk a little bit about how you guys made decisions about when to add services and what services to add?
Yeah. So we tried to start with where the need was. So some examples are, back when we started, dental services were not covered for adults; they were covered for pediatrics. But where the real need was in our neighborhood was the adults. So there were some dentists that would come and they would do the fluoride treatments, but they didn't want to do the restorative work. So we ended up doing, because the restorative work wasn't paid very well by Medicaid. We're doing during the preventive stuff was, and the adults weren't covered, but that was something. Or optometry still is not a PPS service in Illinois for Medicaid, even though it is in most states. But that was a real need. We had a lot of diabetic patients. We needed to get them screened, and so what we tried to do, and then also we started focusing on the adult population. So a lot of health centers start off because Medicaid early on, the early years, was not covering the adult population that it is now. It was pre-Affordable Care Act, and even before that, is that they just wouldn't cover the low-income adult population. Well, the way to do that is you need to hire docs that are interested in taking care of the adult population. So we were seeing a lot of health centers that were hiring a lot of pediatricians and family practice docs that wanted to focus on OB and pediatric. But we deliberately went to look at, hey, could we attract docs that would take care of the sick adult population, because that was a need in our neighborhood. So that was really important to us. We also realized that our future was going to, I kind of talked before about taking more financial accountability for outcomes, is that was important, but it meant we had to build reserves. And the way we build reserves is that from the beginning, our staff were really willing to work for less than what they could make someplace else, and we deliberately put that money into reserve accounts. Because the only way you could take on more financial accountability is if you had the reserves. I mean, we're very fortunate over the years. We never ran a deficit in any single plan in any 1 year for our population, even though we were taking risk. And we went on to take risk when Medicare went to managed care in '96. We took the same degree of risk we did for Medicaid, did it for commercial with United and Blue Cross. So we were careful with it, but we also learned how to manage that risk. And a lot of it is identifying who are the really sick, complex patients that you need to treat differently. By that, I mean doing home visits. We took care of our own patients in the hospital. We went to the nursing homes, because those are the complex patients that if anyone needs concierge medicines, it's those highly costly. But if you manage them and you're willing to go do home visits and those other things, you actually could do pretty well in managed care. Mm-hmm. But as we would generate those dollars, we would put them into a reserve account. I think early on, we knew our Robert Johnson money was going to expire. And again, we had no anticipation of FQHC lookalike or $330. So we actually would even putting money away in the early years when we were charging $5 and getting $13.65 because we thought, well, how is this going to be sustainable when the foundation dollars are over? Because the foundations have made it clear, hey, they're not interested in adopting us forever. We were fortunate Robert Johnson had the foresight to say, well, you need 8 years of support, but we built reserves even at that time.
Did you ever go back overseas? Did you ever do anything else after Liberia?
Yeah, I went to Afghanistan twice. So we did, Rob Werner started going with his family. Rob and Lisa went to Afghanistan. Rick Donlin and out of Memphis and Christ Community there had adopted, and we're sending some people over to Liberia. He convinced Rob and Lisa, and they prayed about it and thought that's what they should do. And then eventually our pediatrician, Jerry Amanis, went over there. So we would rotate, we'd go over for 4 weeks, 5 weeks, and send groups over to support. Not nearly the commitment that Rob and Lisa and Jerry and Jan, his wife, did. But we did go over there. So I did two times over in Afghanistan.
Yeah. I think that there's an awful lot of the pioneers in the CCHF world were people who had connections with overseas work or initially thought that that's what they were going to probably do. And appreciated it. It's not that they went and didn't like it and decided to do something different here, but they just saw that the needs here and what people were doing there's a connection. Um, I, People ask me all the time, is CCHF exclusively domestic? And I always say, well, the earth is the Lord's, so it's all domestic to Him. You know?
Yeah.
And God doesn't think of domestic and international missions. He has one global mission, and it's very much connected. And so,
Yeah, we've had several docs that would come and work for us, but their goal was still to go overseas. So Scott and Jennifer Myrie, who spent their career in Africa, but they came and worked with us for a few years. Mark Zimmerman came; he eventually went to China. So we had docs that would come that were still intended to go overseas. We weren't trying to discourage them, but some of them were coming and paying off their debts. They were health service corps people, and they spent a couple years with us, but always didn't change their mission. And then sometimes we would have docs that would come on their year of furlough and work with us for a year. So we gave them that was a good opportunity as well. So you're right. It tends to draw the same type of person who is very interested in saying, hey, how can I have an impact for those in most need of my particular skills?
So it's been a number of years since you've been here on staff at Lawndale, and you're currently working in a setting as a consultant where you're seeing healthcare from a 30,000-foot perspective. We've talked a little bit about this morning, but how do you see healthcare? How do you see how healthcare has changed since you left Lawndale, and then where do you see it heading? And what are some of the people that are going to be watching this are people who are in their training and who are thinking that God's stirring in them to help do something to address some of the needs that are just around the corner from where we are. Could you speak to that for a minute?
Yeah, I think we've heard, docs have heard about value-based care for a long time. I think it's finally coming to fruition. And I think they think about it particularly, often we think about it from a financial perspective, but I think we need to change the way we pay for healthcare services to allow us to offer those healthcare services in a better way. By that, I mean is getting off of a fee-for-service system, saying what historically, so we did that early in Lawndale. We took primary care cap. We actually designed with 4 other clinics in Chicago the first capitated alternative payment model for FQCs that took our RAP payment, which was fee-for-service, turned into capitation. And what it says to us is, I'm going to pay you a certain amount of money, but now you're accountable for the outcomes. You're accountable to access. And what it allows you to do is be really creative on how you provide access to care. It allows you to use the full care team. It allows you to provide services via a medium that is not billable. So whether that means responding to your patients over the patient portal, whether it's a phone call, whatever it is, whether it's group visits, whether it's using, hey, how do I better use my full care team in terms of my MAs, my community health workers, non-billable members of the care team. I really think that we have to redesign care. There's not enough primary care providers now. The pipeline is even becoming less adequate going forward. Our population is aging, which means they need more primary care. And whenever there's a shortage, it's communities like this that get shafted, right? And so I think we have to be creative in terms of how we provide access to care, how we use our care teams, and how we get paid for healthcare. The idea of just saying, hey, we're doing really good work, therefore you should pay us more in terms of a fee-for-service reimbursement. I think that strategy has worked for FQCs for decades. I think it's not a strategy for the future. I think it's very much moving into, hey, am I accountable for the total cost of care for my patients, and how do I redesign care to manage that? How do I make sure that when I'm managing people so they don't have to go to the emergency room, how do I manage their ambulatory chronic conditions so they're not being hospitalized? If they are hospitalized, how do I manage transitions of care? How do I address their behavioral health needs? And now increasingly, finally, is how do we address their health-related social needs? that in fact it's really pretty clear that the burden is not just a disease burden for them in terms of what their conditions are, but it's the burden of being in communities, under-resourced communities, and it's being the burdens of some of those social related needs, that those are complex patients don't have the enabling resources they need to keep themselves healthy. So I think the future is very much about us being accountable for patients' outcomes, which I can tell you when we started the clinic, that was not our thinking at all. It was all about, hey, if they decide to walk in the front door, we're accountable for taking care and giving good quality care and making sure their diabetes and their blood pressure are controlled. I think what we learned with managed care starting in the late 80s was that we were accountable for people that didn't walk through our front door, which mean outreach and engagement. And so I think that's really where things go. I think we have to redesign how we provide access. I think the healthcare system is a service industry, but it hasn't recreated itself. So if you go look at, hey, how do we go see a movie now? I mean, it used to be the only way you could go to see a movie is go to the theater at a place that was convenient for them, not me, at a time that was convenient for them and not me. Now you can stream whenever you want. We bank from home. We make our deposits from home. We shop from home. Those service industries have redesigned how they provide access to their services and listening to their customers. I think we haven't done that in healthcare. We moved that way to some extent. We're forced into that during the pandemic as far as telehealth, but we have a long ways to go. I think those of us that continue to redesign how we provide access to care and how we get paid for care is going to meet the needs of our community. So I would urge us to not be so stuck into, hey, we have our PPS rates as FQHCs and be paid fee for service. And my job is to make sure that I get billable visits so I can pay my staff.
Yeah. Medicine as an industry, which is unfortunately how we think of it in the United States, medicine as an industry is designed to deliver medical care. We're designed to practice medical care. And so we need to just perpetuate that. But medicine's value is whether it makes people and communities healthier.
Right.
And there are groups that focus on caring for Medicare patients predominantly, and that have tended to focus on, in my mind, stealing Medicare patients out of the communities that we have been called to love and serve. I have concerns about those things because these are not organizations that are bringing resources into a community. They're organizations designed to take resources away from those communities and to pay stockholders and shareholders and things like that. But we have some things to learn. And I appreciated Bruce Miller used to always talk to me about, I'd ask him about such and so an organization, and he would say, they're a really good competitor for us. And I would say, what is a really good competitor? And he said, anybody that makes you think out of the box and makes you try to figure out how to do better.
He's absolutely right. And so when those come into communities like this, they're interested in the high cost individuals
yes,
that have bad outcomes because under a value-based payment arrangement, the money is there if you can improve. If you can improve their outcomes, reduce their costs and their savings to have, and that's their financial model. But what they do is they say, well, why is it that those patients have health status that they want? And a lot of times it's because we're not providing convenient access. So what they've done is they've listened to those consumers. They've redesigned how they provide access. So shame on us as FQHCs if we don't listen to that and redesign care. So but as long as we keep saying, well, I could see 3 patients in the time that I go do a home visit for that complex patient. What we learned early on in Lawndale when we had those and still have those risk contracts is it made total sense to go do those home visits because first of all, it was the right thing to need, particularly for those people that were really confined to their homes. They were complex patients. And sending a visiting nurse in there wasn't going to do it, right? Because a visiting nurse would go in there and then there's only so much they can do. And when somebody got sick, they just call 911, go to the emergency room. So the fact that we listened to that, we redesigned how we provide access to those complex patients, then that's what our competitors are going to do. And they're going to take the high cost patients and say, I'm going to provide better access to care. I'm going to improve their outcomes. And that works for us financially. So before we complain about them, we need to step back and sort of say, why is it that they're being successful? Why is it that our established patients who have been coming to our clinics, those Medicare patients or those high-cost disabled Medicaid patients, why is it that they're attractive to those competitors? And to Bruce's point is, if they're providing a better product, then good for them, right? Then that should be the wake-up call to us to say, well, maybe the way we've been providing access to care and these services need to evolve. I think when health equity is about optimizing, allowing all of our patients to optimize their health status, it doesn't mean treating everybody the same. You have to identify who are the special populations that need a specialized approach for them to be able to optimize their health. That's health equity. So to the extent that means we've got to get out of our mindset of people always coming to us in these particular hours to get this particular service, because that's how we get paid. And that's how we keep our operations. We've got to be creative in our models of care. We got to be creative in how we get paid, and we've got to be willing to take some risk and get outside of our usual mindset.
Yeah. My Bible reading this morning was in Isaiah 61 or 62. I read both Isaiah 61 or 62. I just can't remember where this is, but he talks about build up a highway for the nations to come. And it talks about removing the stones out of their way. And I was thinking, this is God's call for us, is that we have to recognize that there are stones in the way of people getting to what God's answer for them is. And whether that's the gospel or whether it's healthcare or whatever it takes for them to have abundant life and to thrive as people that are created in his image, we have to learn how to recognize those stones and to move and do the hard work of moving them. And I think that's what we're talking about here. But I appreciate your insight. I appreciate your continued engagement in the CCHF community. You and I don't get a lot of time together, but everywhere I travel, people are like, "Oh, we just had Art in, and he, helped us with a project or did various things." And so I appreciate just the gift that you've been to this community and to this movement.
It's been a privilege.
Yeah.
It's been a privilege. CCHF has been really important, certainly in my personal development and in the development of the clinic. And I've had the benefit of working with a lot of really committed mission people from our neighborhood, as well as people that have, professionals and others that have come in and been part of this ministry. So it's been exciting.
Well, thank you for your faithfulness and for the foundation you laid for a lot of us. So, and thank you for this morning.